So, good morning, everyone, and thank you for joining us today for another Upside Insight webinar. My name is Tracy, and I'm one of the nurse educators here at Insight. It's my pleasure today to be introducing Associate Professor Mark Daglish, who is the Director of the Addiction Psychiatry at the I was going to say Redcliffe, the Royal Brisbane Hospital and Women's Hospital, and also the Senior Staff Specialist at Roma St and Melaleuca opioid clinics. Before we get started, just do a little acknowledgement, please, for the traditional owners and custodians of the land on which we are presenting today. So that here for us is the Yagara and Turrbal people in Brisbane. I'd also like to pay my respect to elders past, present and emerging, and I'd also like to extend that respect to any Aboriginal or Torres Strait Islander peoples who are joining us today. There we're going. So it's been a while since we've done a sort of a live presentation. It's getting back to the working it all out again. So a bit of quick housekeeping. I think most people are comfortable with Zoom these days. Any questions you have, stick it into the chat there and we'll do our best to give that to Mark at the end of the presentation. If you're having any hassles with the webinar, seeing it or anything, you can pop it in the chat and we'll see if we can help you out there. But anyway, after all that, I'm going to hand you over to Mark and for our lovely presentation today on what did you expect? Are we neglecting the psychological aspects of the LAI?
Good morning, and thank you for that introduction. This is a sort of rehash of any of you who I think it was the dinner before Wales. I did a variant of this talk, and I've been mulling it over, and I'm still trying to work through the ideas that I think are important here. But this is a kind of work in progress and a bit of a thought experiment. But we'll see how we go, and I will be interested to see what comes up in the questions. Firstly, I'll just add my acknowledgements to the traditional custodians of Meanjin, Brisbane, and pay my respects as well to elders past, present and emerging. I have a few disclaimers, but I don't think any of them really are relevant to today. I'm going to be talking about the LAIs, and I have been involved in advisory boards, but this is really about things other than the pharmacology. So start by telling people what you're going to tell them. I'm going to talk for an hour about nothing. But it's a very specific kind of nothing. And the best example I could come up with for sort of conceptualizing the type of nothing that I'm going to talk about is this old poem about yesterday upon the stair, I met a man who wasn't there. He wasn't there again today. I wish that man would go away. That's kind of the type of nothing that I'm going to be talking about. So I'm going to describe the problem. I'm going to talk a little bit about things, psychological aspects. My apologies to any psychologists in the audience, because this is a psychiatrist's version of psychology, which is not the same. But I'm working on it, and I've been fortunate enough to work with enough psychology colleagues over the years to pick up a few things by osmosis. I'm going to talk specifically about expectancies, placebos, nocebos, and I'll explain that word caricebo when I get to the end. And then some ideas about what I think this means to us as clinicians working in the field. So what's the problem? I've noticed we've been playing with these injections now for what, 3-4 years, give or take. And there's definitely a group for whom they've been absolutely wonderful and magic. But there seems to be a group that don't quite seem to do as well. And some of the recurrent themes that people have talked about to me are, it's just not working, doc. It's not holding me. And you know, people who are coming back a little bit earlier every month for their next injection, looking for, oh yeah, I'm missing something. You know, I'm just not quite as settled as I was. And then we've certainly got a group that have come in on relatively low doses or medium doses of Suboxone and Subutex, but have ended up on, sort of 300 a fortnight of Sublocade, or, 160 of Buvidal every 3 weeks. When previously you're looking at those dose equivalence tables and thinking, I don't understand why, because you were on a much lower dose. So that's the kind of problem that I've been noticing. And it's sort of a gradual realization of there's something going on here. I'm not quite sure what it is, but there's a something. So then I started to think about, okay, well, what is that something? I don't think it's a single something. Sorry, I'm beginning to sound like that advert in the cinema. I had to make a small something into a big something. I'm not trying to sell you advertising. But I don't think it's a uniform phenomenon. I do think for different people, it is a different cause, a different thing that is going on. I think for some people, it is the pharmacology. I talk to people about, we've got Sublocade on the left and Buvidal on the right there, but I think we've pretty well characterized what the average, and I'm deliberately using the imprecise term average there rather than median or mean or mode or whatever, but I think we know what the average response is in terms of plasma levels and serum levels of buprenorphine from these injections. What I don't think we've really got our hands, properly, or a handle on yet, is what's the normal range. And in particular, I think you notice the manufacturers all put the standard deviation or the standard error or the 95% confidence interval vertically. So we know that, at time X, there's a fairly narrow band of where somebody's plasma levels are likely to be at. What we haven't done is turn that on its head and say, at what time do we expect their blood levels to drop below a specific threshold? And if you look at that, the confidence intervals suddenly become very wide. We're going from something that says, oh, you're somewhere between 1.2 and 1.8 nanograms per mil, to something that says, oh, well, you're going to cross the 1.2 or the 2 milligram threshold somewhere between 4 weeks and 6 months. Well, not 6 months, but, between 4 weeks and 12 weeks, and it becomes, so I think there is something in the variability of the pharmacology. The other thing I think we've also not necessarily thought about is, I often describe to people, particularly with Buvidal, you're going to feel for about 3 or 4 days before your injection, roughly how you feel when you're walking to the pharmacy. And you're going to feel for about 3 or 4 days after your injection, how you feel walking home from the pharmacy. Now, for most people, that's exactly the same, but for some people, it's not. And there is, I think, there's 2 transitions that are going on there. There's that gradual transition down into, it's almost time for my dose. And then there's that sudden transition into, I've had my dose. And I think both of those are important phenomena for some people that we need to be paying attention to. And they're psychological phenomena rather than pharmacological phenomena. It's the pharmacology that's driving it, but people don't feel the pharmacology. They feel the subjective experience that results from the pharmacology. And this is where I start to bastardize psychology. Because I think this feeds into the conditioning that is part of substance use disorders and treatment for substance use disorders. So Pavlov and his dogs, the idea of you ring the bell and before every meal, and sooner or later when you ring the bell, the dog starts salivating. So we know that there are stimuli that people are aware of that trigger that sensation of the drug coming on. That they become conditioned stimuli. So that could be something as stark as the flashback in the needle before you push the plunger on the syringe. We know that's, and apologies if I've just triggered any cravings in anybody. But that conditioned stimulus is very powerful. But we also have that from the treatments that we give. Now, the fact that they're longer lasting treatments mean that we try and reduce that conditioning as much as possible. That's one of the reasons for using long-acting medications. But the taste of the Suboxone, the sight of the biodone, the color of the biodone, and well, we know what happened when they changed the color, the dye in the methadone syrup. That, you know, for some people that was quite disturbing because it looked like it was more dilute. It looked different. And that those stimuli, those conditioned stimuli are important, and they're part and parcel of the treatment that we provide. We also know that sort of from a Skinnerian or operant conditioning, you know, I press the lever and I get a reward, that there are certain behaviors that are rewarded. And for a lot of our clients, by the time they come to our service, that's not about, that reward is not, hey, I get to feel high. For most people, that's when I take something, I don't feel as bad. You know, it's that removal of withdrawal symptoms, the negative affective states of distress and pain. But that's still, in psychological terms, that is a reward, that removal of those negative symptoms. And then sometimes there is also that positive effect as well. So we know that these experiences are tied to the experience of taking your medication. So what are these kind of, you know, how does that fit into what we currently do? Certainly the dose of the drug, you know, so there are some people who just, I've got to be on the maximum. I can't, you know, I just can't leave it on the table. You know, if there's a 32 mg dose, I've got to have the 32 mg dose. And that's fine. I mean, you know, that's not greed. That's a conditioned response. You know, the number, a bigger number is better. I also think that rising plasma level, that difference between the nadir just before you dose and then feeling the drug come on, and that experience of feeling that come on, that's nice. You know, I mean, if you don't believe me, think about how different you feel when your blood alcohol is rising compared to falling, even at the same absolute level. So that plasma, that rising plasma level for some people is important. Now, ideally, you know, if we've got somebody stable on something like methadone or Suboxone, that's subjectively less apparent or significantly attenuated. I always say to people that, you know, you've had this pairing for years of every time you use something, you know, you feel crap, you use something, you feel better. So, you know, if I feel crap, the only thing that works is to take something. You know, if I don't take something, I'm going to feel crap. So if you're on the right dose of Suboxone, then that disappears, and how you feel depends on what's going on in your life. And that's what we're trying to do, is to break that link between dosing and how you feel. And that's, you know, when you know you're on enough Suboxone. It's harder to do with methadone, but you know, I'm often talking to people about trying to help them extinguish that link. So that rising plasma level can be important, or in fact, it's probably the rising receptor occupancy, because nobody feels their blood levels. You know, it's like, oh, you know, my blood levels are a bit low. No, what you're feeling is, you know, the occupancy of receptors in the brain. And that warm, pleasant sensation of it coming on, or the removal of that unpleasant sensation of, you know, I say to people when they're asking me about, you know, how do I transition from methadone to Suboxone? I say, well, ideally we get you down to the dose that has you scratching at the window of the pharmacy when they open in the morning. You know, so you're just ready, you know, that's the dose to transfer. Don't mind what the number is, but that's that sort of, you know, so the removal of that unpleasant sensation, or as a colleague or I think as Renton describes it in Train Spotting, you know, he says, I can't feel the withdrawals, but I can feel they're in the post. And it is that kind of removal of that unpleasant sensation. And then I think the other thing that's that's important for a number of people is that reassurance of, I know if I've had my dose, I'm not going to feel bad later in the day. I don't feel bad now, even before my dose, because I know it lasts for 24 hours. But I know that if I don't have my dose, I'm going to start to feel horrible by about 4 p.m. So having had my dose in the morning before I go to work, then I know, you know, there's a reassurance there because I trust the dose to work. And I think that's the one that really people lost when they changed the color of the methadone syrup. It was that loss of the reassurance of, I'm not quite, I don't quite have the same faith in this that it's going to last the 24 hours because it looks different, it looks dilute. So I think that there's I think that's the kind of things that we're, dealing with while we're talking. So where does expectancy come from this? Well, there's that conscious process of then, okay, I expect, when I inject something, when I take a dose, when I get that taste of Suboxone in the mouth, I expect it to have an effect. And that's the sort of conscious or semi-conscious manifestation of the effects of the conditioning. And for expectancy to work, people have to believe it. It has to be plausible, but they have to believe it. I sometimes talk to people about, well, yeah, there's the things that you know, and then there's the things that you actually believe because you've experienced it. I can tell you that, this will help your withdrawals, but if you've never had it before, why would you believe me? You may have read it online, you may have said, but why would you believe it? Once you've experienced it, then you believe it. Oh yeah, now and that, I know I'll feel better if I stop smoking, but every time I have a smoke, I feel better. And, so I know I should stop, but yeah. So it's that conscious rationalization, superimposed on the subconscious experiences, the unconscious expectations. So there's that unconscious conditioned learning. But then there's also the positive and negative expectancies. So I expect to feel better, or actually, sometimes I expect to feel bad. We know, for example, that some people really don't like diluted methadone because they feel like it's not as strong. And I think, so you can expect negative outcomes. I expect to get side effects from this medication. So it can be positive and negative. And this is what we think underpins craving. A lot of craving is about, I know I'll feel better if I use, or I believe I will feel better. I expect to feel better if I use. And there's a lot of that kind of stuff in the craving. And we know it underpins the placebo effect as well. So the placebo idea, you're familiar with placebos, I'm assuming that, we know that, in fact, one of the things that's happened over time is it's become harder and harder to demonstrate that antidepressants work. Not necessarily because the effect rates in the antidepressant group have changed, but actually the recovery rates in the placebo group have come up over time. So that it's now difficult to statistically separate. And people have said, oh, this is evidence that antidepressants don't work. I think it's evidence that placebos do work. And that it's not an inert tablet. Just because it doesn't pharmacologically do anything doesn't mean that it doesn't do anything. So placebo, we're aware about. Some of you may not be familiar with the term nocebo or nocebo, which is the side effects you get from a placebo. And if anybody's looked at placebo-controlled trials, you'll know that the placebo arm of the trial in a double-blind trial always have side effects. In fact, I believe in some of the new Hep C treatments, the placebo groups were having more side effects than the folk on the active drug, which the researchers put down to people were having effects from their untreated Hep C that they were attributing to the medication that was actually the placebo. And obviously, as the active drugs were working, those effects of the Hep C were going away. So that meant that the active arm were actually getting fewer side effects than the placebo group. So nocebo effects or nocebo effects are powerful as well. And some of that is about misattribution, but some of it is about, well, I expect to feel unwell. I expect to get side effects from the medication and headaches and lethargy and constipation and gut upset, and and one wonders whether some of this is also involved in some of the food allergy stuff. Okay. We're not the only ones to have caught on to this. Everyone knows that expectancies is what sells things. This is what most of the advertising talks to you about, is that, I expect that my life will in some way be enhanced by the product that I'm being persuaded to purchase. And in fact, the advertising industry have spent huge amounts of money researching this. And unfortunately, we generally can't get to that because it's not usually published in peer-reviewed journals and available to the public. But we know that this expels, and I didn't add the text to that advert. That was there. So the advertising industry is very aware of this. So these are the expectancies that I think people get trained into as part of opiate replacement therapy, that they expect to feel better or at least less bad. And that's reasonable. I mean, that's the message that we sell people. This will make your life better. They certainly expect their dose to do something. And I think for some people, that is that experience of the rising plasma level, that experience of, feeling the dose come on is important, because that reassures me that it's doing something. That's how I know it's working, when I feel it come on. And they expect their dose to last until the next one. And they largely, that's from experience. So it's like, I know that if I have my dose at 8 o'clock in the morning, that I'm going to feel okay until about 4 p.m. tomorrow. Or I know that, or I think, with some people, we double dose and we triple dose, and they expect that dose to last. And oftentimes, I don't know if you've had that discussion with somebody about saying you can double dose, and you're explaining to them what double dosing with Suboxone means. And they're like, well, how does that work? How does it last 48 hours? How's it going to last 2 days? And some people just, no, not trying that. No, don't. It's never going to last. Not interested. And some people, they just don't expect it to last. And oftentimes it's only when they experience it and they're like, oh, okay, this does last. And so there is that expectancy that it's going to last. So what happens when people switch to the injections? Well, we've just taken away all of those conditioned stimuli that are associated with dosing. They're not getting the taste of their Suboxone every day. They're not getting that sensation of the medication kicking in every day. They're not getting that daily chat with the pharmacist, which may have, it may be that actually they get a warm and fuzzy feeling every time they see their pharmacist because they've got a good relationship with the pharmacist and they know what it means. It means that the dose is going to kick in soon. So, or even just the sign outside the pharmacy as they're walking towards it. I know what I'm like every time I walk past my favorite coffee shop. The warm and fuzzies that I get, and then the craving for caffeine that I get from the smell of the coffee. So we've just taken that all away. We're then having to get used to different expectations. So the staff have got their own expectations about, and we all have different beliefs in the efficacy of the LAIs. We're not all uniform. There's a difference of opinions. We've got different opinions about the different brands, about the different strengths, about the best way to use, who might do better with one brand or another, or one dose or another. Should we have them on weekly first? Should we have them on monthly first? And of course, the monthly and weekly buvidal have different pharmacokinetic profiles, particularly in how they come on. So our expectations might be different. We know the client's expectations are different because they tell us so. And it usually depends on which Reddit channel they've been on, or which Facebook page, or which grapevine they're tapped into. So their expectations can be very different. Have they heard about this as being something that's forced upon people in jail when they'd rather be on methadone? Or is this something they've heard about as being, an amazing way of getting freedom from having to dose every day? So what have they come in expecting from the long-acting injections? And then what about their family and carers? We're all familiar with that scenario where, you've got somebody who's doing really stable on opiate replacement, but they're always got particular family members in their ear. Oh, it's just the same as when you were on the street. You've got to get off. You've got to wean down. Are you weaning down your dose yet? You need to get, and the way that can act as a destabilizer. Or we've got other people who, they feel like they don't need the attachment to the pharmacy anymore, but they've got the family in their ear or parole in their ear saying you've got to stay in treatment. So there are key opinion leaders in this field. You know, this, you know, in these decisions that are coming in with potentially different expectations. And again, explanations may or may not make a difference here. And then people have got different routines as well. So you don't have to go to the pharmacy X number of times a week. You're now coming into the clinic or the pharmacy once a month or once a week. That's a different routine. So, well, you know, there is the conditioning component of that about not seeing your pharmacist every day, but there's also the freedom, the difference. So there's lots of things that are missing. There's that setting and the context. You know, we years ago, people have done work with what happens when you give people placebos in different settings. And we know that if you give somebody a placebo in a setting where they would normally use substances, they're more likely to get that missing, they're more likely to get the sort of conditioned withdrawals, because the body sets up the opponent processes expecting to get delivery of drug, and the body's trying to maintain homeostasis. So whereas if you use in unfamiliar scenarios, you're perhaps more likely to overdose because the body wasn't expecting delivery of drug. So there's all sorts of these conditions, stimuli, the behavior, the habits. In some cases, I think the ritual of taking, you know, getting the dose out, pouring it, you know, I mean, I've got a whole load of rituals around my coffee. You know, and I'm sure, you know, some people have exactly the same around their methadone. And there are certainly rituals around, you know, smoking. I was very wedded to my Zippo, even though a match or any other kind of lighter would have worked just as well for smoking. But no, I like that click of the Zippo. So the rituals involved are important, and we've just taken them away. That rising plasma level has gone. That feeling of the removal of the withdrawals has gone. So there's all of this puts together into what's missing. So is this new? Well, the answer obviously is no. I went back, this was the oldest example I could find readily available, from 1977. And this is a study where they took people who had been stable on methadone for at least a year and who'd expressed an interest in weaning off. And then they were randomized to one of four groups. There were the group that they said, okay, you're the waitlist control, so you're going to stay on maintenance. Then there was the other groups who were told, okay, you're in the blind arm, so you're not going to know what's happening to you. And out of that blind arm, there was one group that were kept on maintenance, one group that were on slow reduction, which was, I think, unfortunately, it's just, yeah, so 10% a week. And then the other group who are a more gradual withdrawal at 3% a week of their dose. And then what this graph shows is up the left-hand side is the percentage of people who said, hold my reductions. In fact, put me back up a little. So that, and then the x-axis is just weeks. Now, obviously, people who were being rapidly reduced fairly quickly up to, it didn't take long before, you know, 35, 40% were saying, hold my reductions, this is too fast. You know, so by about week 15, that was, you know, a third of the group or more. The folk who are on known maintenance, which are the tiny little dots, there's a few of them who said, oh, well, if I'm on maintenance, I might as well be on a higher dose, so just bump me up a little. And that got up to about 5% and then came back down as people just sort of, nah, settle me back down where I am. And that settled at about 2%, who just basically just said, no, I want to be on a little bit more. But the gradual withdrawal, which is the dashes with the dots, the GW group, they had a much slower onset. And even at the end of 30 weeks, which is over 6 months, about 10% had said, you know, pause my reductions, I'm not happy with it. But the blind maintenance group, so this is the folk who thought they were reducing, behaved like the gradual withdrawal group, not the people who knew they were in maintenance. And so we're familiar with, you know, we've all done, you know, blind reductions with methadone. It's one of the things that we talk about that we've lost with people who, you know, who are on Suboxone compared to methadone is you can't do blind reductions. And the fact that that's about, you know, 10%, that kind of feels about right to me. You know, there's a group who blind reductions are just nope, I need to know what dose I'm on. I need to be in control of my dose. I need to know when I'm reducing it. You know, I need to drive this. Absolutely fine. But there's a group who are like, no, no, no. If I know I'm reducing, I'm going to get withdrawals. And about 10% feels kind of, yeah, that's been my clinical experiences about that. So this is not a new phenomenon, and we found various new ways of dealing with it over the years. Unless you think it's just methadone. Just this is a quote from one of the earlier buprenorphine trials where they were looking at withdrawing people off buprenorphine, again, double blind. So the patients, clients and the researchers didn't know who was withdrawing and who was on maintenance. But like a lot of these things, the best predictor of the severity of withdrawal symptoms was how bad do you expect your withdrawals to be? The answer to that question. So this is, yeah, we know this. And it's not just buprenorphine, it's not just methadone. We know that double dosing, some people just don't like it. They don't expect it to last. It just doesn't seem to work for them. We know that, the same thing happens with nicotine. In fact, one of the things I often talk to people about is trying the nicotine inhalator in addition to their patches. And then after a while, just stop replacing the cartridges. Keep using the inhalator, but just stop replacing the cartridges. Or, let them expire, or use them. So, we've seen these kind of phenomena before when people are coming from heroin into opiate replacement or opiate agonist treatment, that it's not the same. Injecting something twice a day is not the same as swallowing something once a day or sticking something under your tongue every 2 days. There's a difference in the expectations. There's a difference in the experience. And we've certainly had the same with benzodiazepine weaning. One of the tricks, for example, I will do with benzodiazepines is if somebody's on 2 5-milligram tablets, when I next do a reduction, I won't go to 7.5, I'll go to 8. And I'll give them 4 2-milligram tablets because, hey, 4 tablets is more than 2 tablets, even if they're a different strength. So I will play with these things. So if this is a thing, and that's what we think we know about it, what do we know we don't know? And I'm not going to get into Rumsfeld territory. I'm not going to talk about the unknown unknowns because I don't know what they are. But the known unknowns, we don't actually know what helps. We've got some ideas, but as far as I'm aware, I don't know of anybody sort of looking at this specific phenomena. We don't know, for example, if walking people through and explaining them, and I try all sorts of metaphors to try and help people understand what's happening. I talk about, why do you not get withdrawals when you switch from the 300 to the 100 of Sublocade at month 3? And I talk about, well, you need 2 big doses to get you up to cruising altitude, but it only takes a lower dose to keep you there. Or I'll talk about the first one has to work on its own, but by the time you get to the 3rd injection, there's a gang of them all working together, so you don't need as much effort from any one injection. So I will talk about different metaphors. I have no idea whether that works. My guess is it helps some people and not others. One of the things I think is we don't know is whether or not placebos help, because we know that placebos have effects, and we think we're playing in the same area. Some of you may have heard Hester Wilson talk about some of the early Buvidal trials, and one of the participants in those early trials decided to dose themselves every day with a Listerine breath strip for the first week on the injection. Just a strip on the tongue that dissolved, and they found that was helpful in getting used to being on the injection. I have wondered about playing around with some of the buprenorphine Suboxone placebo dummies, whether they might be useful, but it's difficult to prescribe a placebo because they're not on the lam. So I don't know. The other thing that I think we know we don't know is whether or not choice makes a difference. I strongly suspect this makes a big difference. You know, if you've chosen to go on to the injection because you think it's going, you know, because, well, what are your expectancies? Whereas if you feel like you've been press ganged, forced, I suspect that you're more likely to identify problems with it. I mean, I still remember, you know, some people saying to me, you know, oh, I just jumped off. Yeah, getting off Suboxone's easy. I jumped off 16 mgs. Felt like crap for a fortnight, but what do you expect? But that's fine, you know. And then other people are like, no, 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 I can't get off that last 2 milligrams of Suboxone because I get withdrawals. It's like, well, both are true. So I think what people are choosing probably does also make quite a difference here, but I don't know. And I don't think anybody knows. Can we steal from elsewhere? So what do we do for similar situations? So blind methadone reductions, we definitely do those. We know that they help for some people. What about nicotine inhalator? You know, that continue to use them when they're empty. We know a number of people try to go to nicotine-free vaping. Of course, we know that sometimes that's not a placebo. You know, and actually, that's true. I haven't thought about the word for when you give somebody something and you tell them it's a placebo, but it's actually the real drug. Yes, yes, that's a whole other talk. That trick with the diazepam that I tend to do about going from, you know, 2 5 mgs to 4 2 mgs. And, you know, I'll do similar things with Suboxone as well, or Subutex when I can. Explanations, choice. So these are the kind of things that we've tried for other scenarios. I think also just giving this experience meaning matters. You know, telling people that, yeah, I think this is a real phenomenon. You know, that what you're talking about is, you know, I think a sort of response of, well, the pharmacology says you should be fine, so therefore you're fine, is not likely to be helpful. So I think, yeah, okay, yeah, this is an experience that I've heard from a few people. We're still trying to work out what it is. It might be the pharmacology, but I think there might also be a psychological component. And, you know, and I've tried some explanations. I don't know. I have started to say to the people, well, if they're on Sublocade, they say, well, at least if you can feel the lump, you know it's still there. So you know it's still dosing you. So that might be a reassurance that it's still doing something. I have wondered about giving people placebos. You know, well, if you feel like you're in withdrawal a week early, how about you have a pack of these placebo strips and just dose yourself for a week in the run up to your next injection? See if that helps. Some people, and again, this is where you know, you're not supposed to do this and I can't recommend this, but off-label and unapproved, I have also occasionally topped people up with Suboxone on top of their injection. And I've treated their injection as a vaccine against unintentional overdose for the next month, but I'll give you some Suboxone every day because that's the treatment that you're looking for to manage your cravings for opiate use. Now, that's completely off-label, outside the guidelines and off the lam, but I've got 1 or 2 rather unusual clients who come and see me, and, well, yeah, I mean, that's what my job's supposed to be. I'm supposed to be seeing the ones that are having difficulties with routine treatment. And I do think choice is important. And I think the other thing is that freedom to change their mind. Okay, you wanted to give the injections a go. Don't feel it's working for you? Fine, you can choose to go back and we'll help you with that. So I think, and telling people that up front, that you can try the injections, and if you don't like them, we'll help you change back, in the same way that you can try to switch from methadone to buprenorphine. We'll help you with that. And if it doesn't work, we'll help you change back. You know, there might be a bit of curly stuff that we have to manage along the way, but we'll get you through it and we can do that and you can choose. And I think that freedom to know that it's not an irreversible decision. The other one I like is you don't have to make the decision now. You can make the decision when you're ready. So that freedom to decide when they're going to decide, I think that's also. So I think this is a thing. I don't think we have a name for this thing. because I had to do, talk about lack of choice, I had to do 3 years of Latin at school, so and a year of Greek. So I'm going to propose. So placebo, we know, means I shall please. That's the derivation of the word. Nocebo means I shall harm, and we know that term. I think we should potentially call this caricebo, which translates as I shall miss. So the response to not get, I wish I could come up with a good phrase. Some of you, any of you who saw Mark Oriacombe talk about craving at IMAA a few years ago, he talked about craving because he said we don't have a word for it in French, which is an interesting cultural note in itself. But he said, so he'd had to explain it to the French researchers, and his description of craving was unwanted wanting. And all of us went, oh, that's genius. I haven't found a good way of explaining what caricebo is. The best I can come up with is a response to not getting an expected treatment, but it's more than that. I haven't got a pithy phrase, but I would love if anybody can come up with something as pithy as unwanted wanting. But I'm thinking caricebo, as you know, being the classical scholar that I was forced to be as a schoolboy. Geez, how many stereotypes am I ticking boxes for? But that's kind of where I was at. So, yeah, that's where I've got to. I would love to know what other people think. Do people think this is a thing? Have people got other insights into this? Do you have ideas about what we might do to help people through this? I would be, yeah, it's very much a work in progress and a thought experiment at the moment. But yeah, I'd be interested to see what people have thought about so far. So over to the questions. I don't know what you've got in the chat going on.
Yeah, thanks, Mark. Now, we do have a couple of questions. We do have a couple of observations. And
cool.
So from my practice, that's what I see, that there is that psychological effect there. It does play a big part of it. But we do have one question. At the transition from longer-term maintenance treatment with methadone or buprenorphine to the LAI, do we actually identify to clients as standard that there may be some negative psychological effects or a loss of connection? Is that something that's being put into practice at the moment?
It's certainly something I walk people through with all aspects of their treatment. You know, when I'm talking to people about choosing between methadone and buprenorphine, or even coming onto the program at all, and then when I talk to people about going across to the injection, I do talk about, you know, how much do you need that daily routine of dosing? How important is it to you? You know, is it your for currently the thing that gets you out of bed in the morning? Is it something that you need? Is that reassurance that you've had your dose each day? And I would also talk to people when I'm trying to help them differentiate between the two brands. You know, how psychologically do you feel about injections and the size of those injections, or is just one injection as bad as another? Do you worry about that experience of feeling the dose going, you know, the blood levels falling or rising? Does that something that you notice? I mean, some people are more interoceptive than others. So for some, it's completely alien and they don't know what I'm talking about. And others go, oh yeah, no, I like that feeling of the dose kicking in every day. So I absolutely talk to people about this when I'm trying to help them decide, one, whether they want the injection, and two, which brand, because I think the pharmacokinetics are similar, but they're not identical. And I say to people, look, it's the same drug in Suboxone, Subutex, Sublocade, and Buvidal, same drug. The thing that's different is the slow release preparation that it's contained in. And I also say to people, for most people, it doesn't make a difference and you'll be happy with whatever. But for some people, and I don't know if that's you, these are the differences that some people notice. Do you think any of those things are important to you? So it's not just about whether or not they're happening, but also whether or not they're important. So that's the way I work, but it's kind of difficult to codify into sort of things like guidelines, other than you should discuss the pros and cons. But the pros and cons are so individual.
Yeah, we actually had a couple of sort of supportive comments around this way, and one from Rose is just saying that she's had experience with a few clients that have been sort of pushed over or moved over to her with the expectation that they'll move to an LAI. And in talking to them, she's found that they're actually quite isolated, and that going to the pharmacy and interacting with the pharmacist and talking to the shopkeepers as they go past and having that walk was their only reason to get out of the house for the day. So they were already thinking, I'm not going to cope with this. And they was considering that their mental health would probably decline because they didn't have that interaction anymore. So there was an expectation that it wouldn't work, but also problematic that it could actually cause them negative effects from that as well.
Yeah, I mean, I think we have to remember that people's experience of the interaction with pharmacists can be very variable between people and between pharmacists. And that for some people, it serves exactly the same purpose as the daily ritual of getting out into the daylight and walking down to the local coffee shop and getting my dose of caffeine. Walking down to the local pharmacist and getting my dose of methadone or Suboxone in the morning is fulfilling exactly the same mental health function. Just slightly different decor.
Yeah. Has there been sort of a note of higher level of engagement in psychological treatment for those taking LAI to maybe talk about some of this stuff or extra counselling?
I mean, I think it would be great to engage more people who are in opiate replacement into the psychosocial components of treatment. I mean, the pharmacology will only get you so far. I think the problem is in a resource-strapped environment, and that resource, both on our side and on the client's side, the pharmacology is often the only thing that they or we are able to provide. In that, one of the reasons I want to go on to the injection is that I really can't afford to be taking the time off work because I'm casual, and if I don't work, I don't get paid. So if I can come in once a month, ideally an evening or a weekend, to get jabbed, and I don't have the time or resources to be able to come in frequently enough to make use of the psychosocial support. I think sometimes it does enable us to, I still remember one of the first people that I put onto the LAI was so that they could go to rehab, where the rehab was willing to take them on the LAI but couldn't facilitate dosing any other way. So I think, again, horses for courses, and for some people it works one way and for some people the other. But I mean, there's always an opportunity to say, well, is counselling something that will be useful for you? Is the psychotherapy, do you need, is this going to give you the stability actually that you stop having to focus on going to the pharmacy every day? Now you have got time to go to, DBT once a week now, or twice, or a group program, So I think it varies.
Yeah. I'm just wondering, a lot of this was about clients that are switching from oral treatments to the long-acting. Do you find that those that have maybe not been engaged in the program before but are used to regularly self-medicating, is there the same sort of psychological thing going on there, or is it a less because they don't have that expectation?
Again, I think it's not going to be the same for everybody. I think when you look at some of the people who've come to us through the sort of chronic pain, opiate maintenance, chronic pain treatment route, sometimes I've sort of talked through the injections as being a way of doing, if you like, high dose Norspan. And that in some ways it might actually be better for pain. So, getting onto the injections sooner rather than later. I think, if you're talking about, and, some people are used to taking, street methadone, again, that idea of once daily dosing being adequate and once a month would be great. So that I now have a choice about whether or not I use, instead of feeling like I have to use every day just to feel well. So I think sometimes that, on the other hand, if you think about, somebody with a significant heroin use disorder, they're going to potentially be injecting 3 or 4 times a day, and the jump could actually be more stark there because you're going from something that's much shorter acting, quicker onset. So again, I think it's not going to be a uniform experience.
Yeah. So we did have another comment just from one of the participants saying that they run a large pharmacotherapy clinic and they found that giving people more appointments gave them more support. So even though they weren't coming in for regular medication, just coming in for those appointments, it sort of helped them out as well.
Yeah.
Also, there was you were talking about the choice before, and one of the participants is saying that they found that that can be a big thing, that there is has been a big push for people to move into the LAI, with a lot of clinicians and services saying, you know, this is going to be cheaper for you, this is going to be better for you, this is so putting a lot of that expectation out there. And then the clients maybe not adjusting to it as well because they haven't had that choice. It's been more of a push.
Yeah, I mean, I think it's very easy for clinicians to have a look at. It's very easy for clinicians to look at the different treatments on paper, and it's relative. You know, the idea of, hey, look, we can give you an injection once a month, and that's you fixed. You know, that on paper, that's kind of what it looks like, and that's, you know, and it's like, well, why wouldn't you? And you know, we kind of get carried away with our own enthusiasm, so we don't necessarily mean to coerce people onto. And then there are times when actually we're saying to people, look, things are so chaotic that really the only way we can see that we can safely provide treatment is through an injection, and I think, and there's going to be a whole spectrum in between there. So I mean, at times we do get a little coercive. We don't have compulsory treatment here, but we sometimes give people fairly stark choices. You know, do you want a monthly injection or jail? You know, but you know, that's not compulsory treatment. So yeah, I mean, again, it's all these things are a spectrum, and I think as long as we don't lose sight of not everybody's the same and there is nuance in everything, then we're going to be okay.
Mark, James here from in the room here in Biala. I guess it's sort of a / question comment, and you were talking before about, you know, is it a thing? Yes, definitely believe it is. And you're also talking about borrowing, I guess, from what we know. And I can only think back to an experience probably in the early days when Sixth Floor here in Biala was doing the trials with the LAIs, and I was working up the road, and we had clients coming down here sometimes because it was perceptions that that was going to meet needs of other parties better. But we found, and I guess that borrowing, one of the things that we did with a couple of clients was, I guess, pull in a lot of that idea of activating clients' own observation, so that you were right what you said before, you know, talking about things is important, psychoeducation tutorials, all those sorts of things, but until you have an experience, change doesn't happen. You can talk about it as much as possible. So using those things like monitoring, we use different ways to do that. By activating that people often found some of that global bias around things being, you know, at this end of the scale in terms of severe or difficult, that they were able to note that it changed, it was different, it wasn't as impactful. So it's the things that you often do in working with things like anxiety, depression, cravings, where people are looking more, I guess, in depthly at what's happening on a day-by-day basis and bringing that in. So just that process of using sort of monitoring logs and activating people's own, being detectives in their own life, they're often able to reduce some of that worry and concern that came from that. Just an idea. And also just to say, from a psychologist's point of view, your view, you've done good. You've done good.
I've worked with a number of colleagues, including yourself, over the years that have gradually, through an iterative process, got me closer to where I needed to be with my psychological understanding. Yeah. They even let me teach on one of the psychology courses now, but only about medication.
One last comment before we go, and I think this is a really good one, that one service has employed peer support workers to provide that extra support required. So I think that's really good move forward.
Absolutely, and I think there's a face validity to an opinion from a peer support worker, or particularly a collective of peer support workers. And I think one of the things people will always say to me, "Oh, does this work, doc?" And I say, "Well, I've had people say it's amazing and wonderful, and they wish they'd been on it years ago, and others who've said, no, I absolutely hate it, and I want to go back to what I was on before." And I've had everything in between. I don't know which group you're going to be in, and just I think that honesty about the peer responses that I've heard have been highly variable, so that I'm not just putting forward that, oh yeah, everyone says this is amazing, because I mean, why would they believe me when I say that? Yeah.
So I think that's all the questions that we've had today, but a lot of comments just saying how wonderful they found your talk, and how much they really loved it, to feel empowered by that information. So that was really good. So thank you very much, Mark, for that presentation. And I'm sure people are going to have a lot to think about moving forward.